I'm going to talk today to you about consensus-based management algorithms for severe traumatic brain injury and whether or not we need these and what they are. I have no conflict of interest for this talk. I'm going to focus mostly around the three recently published and freely available open access algorithms, the CYBIC-1, which is for ICP monitored patients, CYBIC-2, which is for brain tissue oxygen and ICP monitored patients, and the Crevis protocol, which is for patients without intracranial pressure monitoring or brain tissue oxygen. These are published open access and have collectively accessed over 40,000 times, suggesting a really huge interest in the audience. They're readily available, so I'm not going to go into the details, but I would like to discuss what they are and why we need them. In order to do that, a bit of history is needed. In 95, Jamgajar published a survey of level 1 trauma centers in the US and showed that you were more likely to get steroids than ICP monitoring. Now, three of us were sitting together at a national meeting after that study, and we were grousing about that fact. And we felt that if we could just show that the data so strongly correlated use of ICP monitoring and outcome that you had to monitor, if we could show that, then everyone would be forced to monitor. Well, Peter Quinn, then the executive director of the Brain Trauma Foundation, said, if you want to do that, I will make it happen. He did the mechanics, we did the evidence report, and it produced the first Brain Trauma Foundation guidelines. Well, nothing destroys confidence like follow up. And what we found was there was no class 1 evidence, very little class 2 evidence, and almost everything was class 3 evidence. So instead of being able to produce standards of care based on class 1 evidence, all we could produce was options, treatment recommendations based on the lowest level of evidence. Now, one thing we did produce in the early editions of the guidelines was an algorithm. This was hugely popular, but it wasn't evidence-based. We put it in as a tool. We came up with it, sort of generated it ourselves, and it was hugely popular. But it wasn't evidence-based, which we realized after the first edition, and we didn't put it into subsequent editions because we didn't feel that a non-evidence-based algorithm belonged in an evidence report. And this was much to the chagrin of the readership who asked over and over, where's the algorithm? People really wanted the algorithm. Now, in the fourth edition, the last edition recently published, this is a very well done evidence report, but it met with rather lukewarm reception in the audience. It wasn't what people expected. It didn't seem to be clinically useful. It was really well done. Methodologically, this was a really excellent evidence report. However, it's a little bit like taking a fine Scots whiskey, an Islay Scots whiskey, and putting it in a still and distilling it down to absolute alcohol. It's pure, but it's not palpable. You can't drink it. And the guidelines are an excellent tool for research and of great academic value, but clinically, they're weak. They're little value at the bedside in terms of individual patient care. People wanted an algorithm. They wanted a compass. They wanted something to guide their care at the bedside. Now, when you think of the sea of clinical physiology and traumatic brain injury, you think that what we need to do as clinicians is to navigate that sea of physiology to get to our goal of patient care. In the best of all worlds, we would be able to use class 1 studies to get across rigorous, scientifically generalizable studies that can actually discuss causation. But there are far too few class 1 studies to be able to navigate this ocean. We can't use them to cross. So then we can add class 2 studies, which are less rigorous and no longer talk about causation, only correlation. But there are still too few of them to allow us to navigate this ocean. If we add class 3 studies, which are of much more marginal scientific value, there are a lot of them, but even with class 3 studies, we can't get across. What we need are ways of bridging these bits of knowledge into a pathway that allows us to get to our goal of treating the individual patient. Now, clinical experience is really finding out what works when you try it on for size. It's experience is what you get when you don't get what you want. Now, one or two experience is anecdote, and anecdote does not provide evidence. You can't practice based on what you did a week or two ago. However, hundreds of experiences over years provide something more than that. It really provides something that might be called wisdom. And basically that gives you an idea of what to do when the evidence isn't there. Now, the individual expert practitioner practices what they know of evidence based medicine filtered through extensive clinical experience, coming up with something that might be called medicine based evidence. Now, a single institutional experience and a single practitioner will be confounded. Personal bias, technical idiosyncrasies, different patient populations, different care environments, etc., you will bias that individual experience. You may do really well at that institution, but it may not be generalizable to other institutions where the environment is different. However, if you take multiple expert practitioners and you focus them on one clinical problem, then those individual biases will fall out because they don't overlap. And what does overlap and what they end up sharing in terms of where they agree and why they don't when they don't is very useful. And that can be harvested through a rigorous consensus process. Consensus based statements are not binding, they are not class 1 evidence, but they do provide evidence, the class 3 evidence, and they should be looked at more like recommendations. But what do we do as practitioners when we come up against a difficult case? Well, we go to one of our colleagues who might be an expert in that field and we ask, what would you do? But how many of us have a colleague who is a brain injury expert? We probably have colleagues who are experts in sepsis and RDS or in spine surgery and tumor removal, but not many of us have a traumatic brain injury expert, or else we are the traumatic brain injury expert. So then we go to the web, and we know what dodgy information you can get from the web. What the consensus process attempts to do is to come up with a curbside consult that's a distillation of the opinions of 30 to 40 traumatic brain injury experts, sort of a super curbside consult to help with these individual clinical situations. Now, in the overall picture, class 1 evidence is critical. We can't abandon class 1 studies, even though they're expensive, hard to do, and some people say they never produce positive results. They're really the only type of design that will allow us to address causality. They're necessary. We need to be careful where we do them, and we need to do them well, but we can't just eschew them. Class 2 evidence is needed because it provides so much more data. It can't address causation, it can address correlation, but it's really what comparative effectiveness research is about. And class 3 evidence is useful as well. It provides the integration that makes medicine practicable, and it can be harvested through a formal Delphi based consensus to become a useful tool. Essentially, we take evidence based guidelines, which are a critical assessment of a state of the literature on a given topic, and define the level of confidence, of rigor of the current literature, and also often outline the research needs. And we can take what we have of the evidence base and we can filter it through this consensus process where we harvest the extensive clinical expert opinion of applying evidence-based medicine in human clinical cases, and we come up with an ad hoc reasonable algorithm that's useful at the bedside at the present moment. That can certainly feed back to evidence, and more research can be done based on the implications of the algorithms to maybe someday we don't need their consensus process. But currently, this marriage of evidence-based medicine and medicine-based evidence can be very useful at the bedside. And that's what these algorithms are about that are now readily available, and I would strongly encourage you to access these. But the question is there evidence that using a protocol improves outcome? And we do have some. It's really in follow-up of the best trip trial done in Latin America on non-monitored patients. And what we did was we used a group that used the protocol from the non-monitored group in the best trip trial, and we compared them against patients treated at institutions that were not used a protocol. We prospectively collected that data and analyzed it in terms of outcome. And what we found was that treatment with an algorithm, with a protocol, had better recovery and lower mortality across the board, no matter how you measured it. This is the Kaplan-Meier survival curve, and you can see an early durable effect on survival, and the similar effect was held on morbidity. We then developed a consensus-based protocol using that group to come up with sort of a super ICE protocol, a more fleshed out protocol, a new protocol, and we tested it in both groups. And interestingly, what we found was that the group that previously had no protocol and now used the new protocol had results similar to the phase 1 study. And that's that they had better outcomes, mortality, morbidity. The group that had a previous protocol and now adopted the new protocol, their outcomes trended towards better, but did not reach significance. So what it really suggests is that having an institutional protocol saves lives. And also, there's data that improves efficiency, lower length of stay, less use of resources. But the crux seems to be that having a protocol saved lives. The specifics of the protocol appear less critical. So what should you do with consensus recommendation? Well, you can ignore them. That's what we tend to do with new things or things we don't like. Probably not a good idea. You can adopt them, which is straightforward and a reasonable approach, or you can adapt them, modify them to fit your environment. But whatever you do, I would strongly suggest that you do it as a team. You take all of the stakeholders in traumatic brain injury care at your institution and you put them together to adapt or adopt a protocol to use at your institution in traumatic brain injury patients to improve outcome and decrease treatment variability. That's really the use of this consensus process in traumatic brain injury, and that's really the goal of the CIBIC 1 and CIBIC 2 consensus documents and the CREVIS 1 protocol. Thank you very much.